Você é आवाज आ रही है लेकिन
Assalamu alaikum. जी, let's start. सर, डॉक्टर साहब, डॉक्टर हसन, आप सर 2 मिनट के लिए अगर आप अपनी स्क्रीन स्टॉप कर दीजिए शेयर करने के लिए, प्लीज सर. थैंक यू. स्टार्ट करते हैं. Bismillahirrahmanirrahim. Assalamu alaikum. Respected speakers and guests, welcome to Emperor Board Nights of Diabetes, an expert speaker program organized by Farm Evo Private Limited. My name is Murtaza Hussain Khoso, and I'm honored today to be hosting this event in the presence of such an esteemed gathering. Before we start, I request everyone to observe silence for the recitation of the Holy Quran.
بسم الله الرحمن الرحيم.
In the name of Allah, the entirely merciful, the especially merciful.
قل يا أيها الكافرون.
Say, O disbelievers,
لا أعبد ما تعبدون.
I do not worship what you worship,
ولا أنتم عابدون ما أعبد.
nor are you worshippers of what I worship,
ولا أنا عابد ما عبدتم.
nor will I be a worshipper of what you worship,
ولا أنتم عابدون ما أعبد.
nor will you be worshippers of what I worship.
لكم دينكم ولي دين.
For you is your religion, and for me is my religion.
Hello. Farm Evo Private Limited started its journey in 1999 with its vision, our dream, our healthier society. Our passion, creativity, and innovation has driven us continuously to bring unsurpassed medical advances to the healthcare community at large. The name of this digital event, Emperor Board Knights of Diabetes, sets you, the speakers, and the audience as the Knights of Diabetes, the champions of the patients when it comes to taking the decision in defending them against the epidemic, diabetes. The advancements in the research of diabetes have led to the discovery of SGLT2 inhibitors and specifically empagliflozin. Similarly, empagliflozin is identical to a knight in chess, the one and only piece that can jump over its adversaries and change the nature of the game. What advantages does this formidable ally, empagliflozin, has for us? For that, I would like to invite our first speaker, Dr. Muhammad Hassan. Dr. Muhammad Hassan has an MBBS degree and an MRCP from Ireland and an MRCP in endocrinology and diabetes from the UK. He is currently serving as an assistant professor in the National Institute of Diabetes and Endocrinology in DUH's Abuja campus. Sir, please take over. Thank you.
स्पीकर बंद कर थोड़ा सा रहता है स्पीकर होता है फिर बात करते हैं
Bismillahirrahmanirrahim. Welcome all of you. It's my pleasure to be again with the Farm Evo and on this little but very auspicious occasion. आज हम again दोबारा कोविड के इस पैंडेमिक में आपसे मुखातिब हैं और unfortunately we are not having any live gathering, but still This is another opportunity for us to learn and revise our memories and what is essential for our patient and what is important and what can we do for our patient in these testing times. So again, without any further waste of time, थोड़ी सी मुख्तसर सा तारुफ करेंगे and then we move on to the presentation. My name is Dr. Syed Muhammad Hassan and I am assistant professor as working as a consultant endocrinologist and physician and diabetologist at the National Institute of Diabetes and Endocrinology, Dow University of Health Sciences, OJA campus. The topic of today's CME is Spotlight on SGLT2 inhibitor, glucose control and beyond. And this is a very interesting topic because these days, if you are stuck up with a patient who is not achieving a good glycemic control, you have option that can work as good as insulin sometimes, and maybe we can add this therapy to insulin and give patient maximum benefit beyond glycemic control. यही आज का topic है, and I hope that in your practice you may have used it, and some of you may not have experience or may not be using it or may not have a good feel how it works. And how I know that you will be listening too much about SGLT2 inhibitors and GLP-1 receptor agonists and other therapies that are currently in practice, and आजकल इसी का चर्चा है हर तरफ. So अब तक जो हमारे पास therapies हैं डायबिटीज ट्रीट करने के लिए, they are all using some way or the other insulin. इंसुलिन का पाथवे यूज करते हुए हम डायबिटीज कंट्रोल करते हैं, बिकॉज यू नो एक्चुअल पैथोफिजियोलॉजी जो है डायबिटीज की वो इंसुलिन डेफिशिएंसी है या इंसुलिन रेजिस्टेंस है. और इसीलिए जितनी भी थेरेपीज गुज़श्ता 50-60 सालों में हमारे सामने आई हैं वो सारी इंसुलिन बेस्ड हैं. आइदर दे इंक्रीज इंसुलिन सेंसिटिविटी or they increase insulin secretion from the beta cell of pancreas, or itself it is insulin which is working for the control of diabetes. इसमें insulin sensitizers हैं that you can see, thiazolidinediones, pioglitazone and metformin. Metformin is time-tested tool of controlling diabetes, and left, right, central तमाम guidelines जो हैं ADA की, ITF की, ACE की, NICE की, सब start करती है therapy after lifestyle modification and after exercise and after diet. They start with metformin. If it is not working, if it is not tolerated by the patient, if we are not achieving a good glycemic control, if we are not achieving better HbA1c targets, then we increase the dose or we add on therapy. Oh, sorry. Okay, screen share नहीं हो पा रही है. I hope you can see the screen now. So, as you can see here in this illustration that after insulin-based therapies, we are coming to know that there is another organ, very important organ in our body that is also involved in glucose homeostasis, and this is kidney. And our kidneys are previously known to only remove the waste products and any toxins from the body. But now we are coming to know that not just vitamin D activation, but this is also helpful in glycemic control. And this we came to know not very lately, that diabetes is also treatable if we involve kidneys. You know that if glycemic control is not achieved, kidneys are the organs which are affected, and this process even starts in pre-diabetes time. So kidneys are involved in glycemic control and glucose homeostasis, and how it works, let us know, let us learn. So you know that kidneys involved in excreting waste products. They also involved in reabsorbing many essential micronutrients and also some elements and essential molecules that they reabsorb, which are useful for our body. And one of them is glucose. So kidneys leads to control of glucose by gluconeogenesis 20%, and also nephrons are involved in reabsorbing the excess glucose that is filtered through the glomerulus, and about up to 180 gram of glucose per day is reabsorbed. ये इसका threshold है. अगर इससे ज़्यादा glucose kidneys filter करेंगे through glomerulus, this will be passed out in the urine. And this is what happens in diabetes, that since there is excess of 180 gram of glucose being filtered through the kidneys, that we actually observe in the urine analysis report as the glycosuria. So nephrons में जो मुख्तलिफ gates होते हैं, मुख्तलिफ like channels होते हैं which are involved in reabsorption of essential micronutrients and also proteins and glucose. So these are important gates through which kidneys reabsorb. So all glucose which is filtered by the kidney is reclaimed and reabsorbed by the sodium glucose co-transporter, which is in the proximal convoluted tubule, and up to 90% of this glucose is reabsorbed. 10% होता है SGLT1 जो होते हैं इसके gates, उससे reabsorb होता है, और इन channel से ये 10% होता है, which is actually in the later part of the nephron. This is the illustration our nephrology team and nephrology panel will further highlight. Now you can see that this is the nephron, it's a lumen, and this is the basolateral part of the nephron. And once there is a glucose in the interstitium, in the जो भी आपका absorption होता है, and then I think this is the lumen. Sorry. So once in glucose reabsorption takes place through the lumen, and this is taken up by the SGLT2 gates, and this is absorbed by the kidney along with sodium. So this takes water along with it, and in the lumen, so water is also reabsorbed along with the glucose and sodium. Here you can see glomerulus and then proximal convoluted tubule and loop of Henle and the distal part of the nephron. And here, once the absorption. Hello. I hope everyone is able to listen to my voice. So 90% of this glucose is reabsorbed by the SGLT2 channels, and this is in the proximal convoluted tubule. In the later part of the proximal tubule, SGLT1 channels absorb the 10%, remaining 10% of the glucose. So normally, in normal functioning kidney, in normal conditions when there is no diabetes, this filtered glucose is completely reabsorbed by the kidney and none is seen in the urine. But if this surpasses the renal threshold of more than 180 gram, then it is seen in the urine. So normally all of it is reabsorbed. In diabetes, what we see is that if we target this channel, if we target this these gates of SGLT2 receptors, then we can lead to a lot of glycosuria and excess glucose that is being reabsorbed, that will be reabsorbed, will be passed out in the urine, and we will be able to avoid hyperglycemia. और यही इस वक्त का सबसे बड़ा अहम टॉपिक है कि SGLT2 इनहिबिटर कैसे काम करते हैं और इसकी क्या अफादियत है, क्या इसके हमारे पास आफ्टर इफेक्ट्स आते हैं, बेनिफिट्स आते हैं. So by inhibiting SGLT2 receptors, you are reducing the amount of glucose that gets reabsorbed into the plasma, and this is going to increase the amount of glucose that gets excreted in the urine to approximately 60 to 80 grams per day. This is a tremendous amount of glucose that is going to be wasted. and this is going to lose the excess calories. By doing so, you are going to lose weight. The patient will lose weight by excreting excess calories that was previously being reabsorbed. Secondly, by losing these calories, you, and along with sodium, as you saw that the glucose molecule will be reabsorbed with sodium. You are inhibiting glucose to be reabsorbed. Same time, you are inhibiting sodium to be reabsorbed. And by doing so, you are letting sodium and glucose passing out in the urine together. अब ये दोनों मॉलिक्यूल जो है सोडियम और ग्लूकोज जब ये यूरिन में एक्सेस में चले जाएंगे तो इट विल आल्सो हैव सम ऑस्मोटिक इफेक्ट दैट विल लीड टू लॉस ऑफ एक्सेस fluid, and this is going to improve the volume overload. This is also going to reduce the intravascular volume, और इसकी वजह से क्या होता है ब्लड प्रेशर रिडक्शन होती है. अब यू कैन सी जो हमारा असल टॉपिक है कि ग्लाइसेमिक कंट्रोल एंड बियॉन्ड, तो आपका ब्लड शुगर कंट्रोल हो गया, साथ में आपने एक्सेस कैलोरीज लूज किए जिसकी वजह से वेट लूज हुआ. और दिस इज नॉट आई मीन वेरी सिंपल. आई मीन यू कैन इमेजिन समवन ऑन वन सिंगल थेरेपी controlling blood sugar, losing weight, and controlling blood pressure have a tremendous amount in morbidity and mortality and improvement in the overall metabolic profile. So ये बहुत बड़ा benefit है इस drug का. Previously इसका concept था कि चूंकि ये excess glucose pass out होता है urine में, that's going to cause a lot of UTI or fungal infection. But you know, in real practice, these side effects are minimal if you have some precautions. वो हम बाद में बात करते हैं. The metabolic changes जो होते हैं, if you can see that by losing glucose, by losing excess calories, by controlling weight of the patient, it is also important that by losing a lot of calories and a lot of glucose, your adipose tissue will also have beneficial effects. और इसकी वजह से weight loss होता है. So, how much sugar is not reabsorbed? In patients with type 2 diabetes, urinary glucose excretion increased immediately following the first dose of SGLT2 inhibitor and was maintained at the end of 4-week treatment period. So, iska jo impact is very profound and it is lasting effect. Now, it is dose dependent. If you give 10 milligrams of SGLT2 inhibitor Empagliflozin, it will tend to lose 64 grams of glucose per day. और ये बहुत बड़ा amount होता है. Now, if you increase the dose from 10 to 25 grams, जो कि इसकी maximum dose है once daily, so it will lead to loss of about 78 grams of glucose per day by empagliflozin dose of 25 grams. So इसके comparatively अगर आप देखें by comparing this molecule of empagliflozin with dapagliflozin and canagliflozin हमारे यहाँ available नहीं है इस वक्त, but we have two molecules available in Pakistan. One is EMPA and other is dapagliflozin. Now, empagliflozin की डोज जो है मैक्सिमम about 10 to 25 milligram. You can start as low as even 5 milligram tablet, and once daily dose होती है with or without food, preferably after meal दे सकते हैं and daytime, and peak plasma concentration achieved in 1.5 hours. It is absorbed and more than 60% is bioavailability होती है, and then primarily it is glucuronidation in liver takes place, but no active metabolites. Eliminated through hepatic to renal, जो उसकी elimination होती है more dependent on kidneys as compared to liver. So 12.4 half-life per hours होती है. So eliminated primarily by kidneys and also by the liver. Selectivity over SGLT1 molecule जो होता है SGLT1 receptor is 1:5000. So since empagliflozin is SGLT2 inhibitor, इसकी 5000 times more affinity है towards SGLT2 receptor as compared to SGLT1. तो SGLT2 के ऊपर इफेक्ट करने की वजह से जो 90% ग्लूकोज रीअब्सॉर्ब हो रही थी उसका इम्पैक्ट ज्यादा होता है. And glucose excretion with higher doses is about up to 78 grams per day. Now, everything that we are discussing is clinically proven by trials. और इसमें आपने देखा कि if we compared empagliflozin and dapagliflozin, by the way, apart from this lecture, let me tell you that these two molecules are competing each other at every forefront. इस वक्त जो पाकिस्तान में जो कंपनीज हैं और पाकिस्तान में जो फार्मास्यूटिकल कंपनीज हैं, they are promoting both the medications. Both the medications are beneficial and both have got their edge over each other. लेकिन एम्पाग्लिफ्लोजिन जो पहले आई थी, लिहाजा इनको एज है कि ये काफी कंपीटिंग पोजीशन में, दोनों के बेनिफिट हैं, दोनों की ट्रायल्स हैं, दे हैव रोबस्ट एविडेंस इन फेवर ऑफ better metabolic profile, better glucose control and blood pressure control, weight reduction, and better nephrological profile. जो माइक्रोएल्बुमिनुरिया है, दोनों ड्रग्स improve करती हैं. So if you compare, previously we came to know that empagliflozin has an edge of reducing HbA1c of 1.6 point% as compared to 1.2 point% in case of dapagliflozin. If you see both the, another drug, very important, glimepiride. If you compare the two drugs, achieving HbA1c of 10%, so again 1.85% reduction in HbA1c at A1c of 10% as compared to glimepiride when it reduced the A1c to 1.35 point%. And if you see that the impact of empagliflozin in reducing A1c up to 8% was even again more in case of empagliflozin as compared to glimepiride. Although glimepiride is a sulfonylurea, but the A1c reduction was even more profound when it was compared with empagliflozin in case of empagliflozin. So empagliflozin, virtually all glucose filtered by the kidney is reclaimed in the proximal tubule. Sodium glucose co-transporter is responsible for 90% of the reabsorption. Empagliflozin is a highly selective inhibitor of SGLT2 inhibitor, and by reducing renal glucose reabsorption, empagliflozin increased urinary glucose excretion. और यही इसका सबसे important function है जिसकी वजह से सारे metabolic benefits हमें मिलते हैं. In patients with type diabetes, empagliflozin leads to significant reduction in A1c, weight loss, and reduction in blood pressure without increase in heart rate. So again, as I mentioned, हर drugs के कुछ merits हैं, कुछ demerits हैं. Every drug has got its own weak points, side effects होते हैं. इसमें सबसे important चीज ये है कि A1c reduction के साथ-साथ weight loss होता है, blood pressure loss होता है. Major atherosclerotic cardiovascular events जो होते हैं, they are reduced. Heart failure hospitalization is reduced in case of empagliflozin, and revascularization was also less. So, but unfortunately, because a lot of glucose is being excreted in the urine, there is increased glucose content in the urine that leads to sometimes genital urinary infection. Because of tendency to lose a lot of fluid from the body, is sometimes precipitated DKA, and previously it was historically known as that in case of canine glyphosate, more leg, foot or leg amputation was seen because of dehydration and poor intravascular volume. So volume depletion is one of the benefits, as well as sometimes it is side effect. And in case if you don't take enough fluid, it can precipitate acute kidney injury and pre-renal azotemia. This is a busy slide, but let me sum up this quickly. That by glycosuria, it leads to negative caloric balance. It leads to total body fat mass reduction, and then epicardial fat tissue, as you know, that it sometimes leads to reduce in the inflammation and fibrosis. Secondly, A1c reduction leads to reduced inflammation, glucose toxicity that leads to hyperglycemia and its side effects in case of neuropathic exacerbation. All these processes are So I'm sorry that we were disconnected in the middle. So if you see this slide, that by reducing glycosuria, you are reducing HbA1c, and then it also leads to uricosuriya. So it leads to reduction in plasma uric acid, another very important benefit. And by doing all these benefits, you are reducing atherosclerosis and increased cardiac contractility. Number one. Number two, by losing sodium, you are reducing blood pressure, reducing plasma volume, which is beneficial in case if someone has got back. By doing that, it leads to increased benefit to the cardiovascular system by reducing cardiac contractility, reducing arterial stiffness, reducing myocardial stretch, and afferent arteriole constriction is also reduced. Then, when risk of ventricular arrhythmias and activation of angiotensin converting enzyme and angiotensin 1 to 7, these enzymes are also reduced in activation, and this is a benefit in reducing blood pressure. And then again, intraglomerular hypertension and hyperfiltration is reduced. Initially, theoretically, if you see that it leads to excess water loss, excess glycosuria, but at the same time, you can see these hidden benefits, and all leads to better cardiac and renal protection. My friend who are here, nephrologist and cardiologist, they will put some more light on these benefits. But as you know that SGLT2 inhibitor now is a treatment of choice, not just by diabetologists or endocrinologists, but also it is choice by cardiologists and nephrologists also, beyond diabetes control. So if you see this slide, a very important point, what is the recommendation in case of type 1 diabetes of SGLT2 inhibitor therapy? Now, it is actually not recommended for poorly compliant patients with HbA1c above 9% and history of DKA. Because, while losing a lot of fluid, it can precipitate DKA. Consider increased DKA risk in patients on insulin pump therapy. Use lowest available dose of SGLT2 inhibitor required to achieve clinical benefit. So it can be used if someone needs adjunct therapy and someone needs a little hand with the insulin. Reduce prandial insulin by 10 to 20%. Now, this is another very important benefit because the function of SGLT2 inhibitor is beyond insulin pathway. So you can use this in case of type 1 diabetes, and we have currently last year in ADA and ESD, it was discussed that sotagliflozin is one of the drugs that is we used in case of type 1 diabetes. But I think if it is a class effect, it can be used even any molecule can be used, especially empagliflozin. If we talk about in our condition in our country, we have two molecules available, empagliflozin and dapagliflozin. So it leads to reduction in the insulin dose, and you can imagine by reduction of the insulin dose, the risk of hypoglycemia is improved, and the benefits beyond glycemic control like cardiovascular benefit, renal benefit will be also achieved. Reassess insulin to carbohydrate ratios once established on SGLT2 inhibitor. Provide blood ketone meter and advise on DKA diagnosis and management. So you should keep an eye on people with type 1 diabetes that they don't dip into DKA. So they should have urine dipstick to check if they have DKA, and they should keep an eye on their glycemic control and also symptoms of DKA. Advise blood ketone testing. हमारा blood ketone testing नहीं होती है, but we have urine sticks that will check ketones in the urine. Advise stopping SGLT2 inhibitor during intercurrent illness or conditions where there is fluid loss or reduced fluid intake. So people with type 1 diabetes, they should not avoid injecting insulin. They should never quit their insulin. But if they have any symptom that is suggestive of DKA, or they have any intercurrent illness, flu हो गया, diarrheal illness हो गई, कोई trauma हो गया, कोई stress हो गया, of course they need to increase their insulin, and then they should also stop oral therapy, especially metformin and SGLT2 inhibitor if they are taking it. Advise about increased risk of genital myocardial infection and or diarrhea. So especially, you know that by losing glucose in the urine, they can also have myocardial infection in the perineum and melanitis or UTI. So they have to keep an eye on these symptoms also. So by this is my last slide. We have empagliflozin available as 10 and 25 milligram tablet, and this is the end of my talk. I hope you have some questions. If you have any question to the panel and to my other friends, we can answer, inshallah. Thank you very much.
Assalamu alaikum. Thank you, Dr. Saab, very much. बहुत बहुत शुक्रिया. That was brilliantly put. If anyone has any questions, you can write those questions in the chat box for Dr. Saab. We will take questions for now. There will be a Q&A session at the last as well. But if you have any question right now for Dr. Muhammad Hassan, please.
हेलो अस्सलाम वालेकुम।
वालेकुम अस्सलाम जी।
मेरा नाम डॉक्टर मोहम्मद वसीम शरीफ है and I want to ask you what is the best treatment for only the fasting hyperglycemia?
बहुत अच्छा सवाल है। देखिए अक्सर पेशेंट का रैंडम ब्लड शुगर बहुत अच्छा होता है विद इन टारगेट 140 to 160 or 180. Now you need to know if only fasting hyperglycemia is taking place and it is not being controlled, पहले तो आप थेरेपी रिवाइज करें, रिव्यू करें what type of medication this patient is taking. आमतौर से fasting hyperglycemia reflects insulin resistance. So you need to see what are the therapies currently patient is taking and how much is the dosage. Sometimes patient is taking just glimepiride or gliclazide, जैसे कि हमारे यहाँ अवेलेबल है, या ग्लिबिक्लामाइड ले रहा है,
चाहिए ना? हाँ बस ये
प्लीज अपना माइक बंद कर दें प्लीज। अच्छा, अपने क्या होता है कि अगर फर्स्ट करें उसकी थेरेपी में मेटफॉर्मिन शामिल नहीं तो आप मेटफॉर्मिन शामिल कर सकते हैं एट नाइट मील और डिनर के साथ, या अगर थेरेपी में मेटफॉर्मिन शामिल है मॉर्निंग में सल्फोनाइल ले रहे हैं तो यू नीड टू ऐड DPP-4 inhibitor at night time. Now remember DPP-4 inhibitor the benefit है ये कि it leads to inhibition of hepatic glucose output, and this is the one contributor of hyperglycemia in the morning. So you can add DPP-4 inhibitor, you can increase the dose of DPP-4 inhibitor and metformin at night time along with twice daily therapy or once daily therapy. डिपेंड करता है पेशेंट ट्रीटमेंट क्या ले रहे हैं, उसी को आप एस्केलेट कर सकते हैं. लास्ट बट नॉट द लीस्ट, यू कैन आल्सो ऐड, अगर पेशेंट की ड्यूरेशन ऑफ डायबिटीज बहुत प्रोलॉन्ग है, यू कैन काउंसिल द पेशेंट एंड यू कैन ऐड बेसल इंसुलिन एट बेड टाइम. तो बेसल इंसुलिन में आपके पास NPH है, यू हैव ग्लार्जीन, यू हैव डेटिमियर, सो यू कैन ऐड एनी वन ऑफ दीज. तो इसमें आप कर सकते हैं एडिशन. जहां तक ताल्लुक है SGLT2 इनहिबिटर का, this is given once a day. Preferably it is not given at night time because sometimes patient will have urinary symptoms and then patient will have to wake up at night to pass urine. So ideally आप afternoon में lunch के बाद दे सकते हैं या morning में दे सकते हैं after breakfast. ये आप कर सकते हैं. So you have to review the therapy of the patient and you can add any therapy that will avoid hypoglycemia, but you can control fasting hyperglycemia effectively by this strategy.
जी सर, ये मेटफॉर्मिन और DPP-4 इनहिबिटर्स का कॉम्बिनेशन होता है, इसमें सर विल्डाग्लेप्टिन एंड सीटाग्लेप्टिन, तो सर किसका रिजल्ट ज्यादा बेहतर है आपकी नॉलेज, आपकी एक्सपीरियंस में? सीटाग्लेप्टिन इज बेटर देन द विल्डाग्लेप्टिन और विल्डाग्लेप्टिन इज बेटर देन द सीटाग्लेप्टिन?
दोनों ड्रग्स बहुत इफेक्टिव हैं, लेकिन मजे की बात यह है कि सीटाग्लेप्टिन और विल्डाग्लेप्टिन में एक बहुत माइनर सा फर्क है और ये बहुत ज्यादा प्रोफाउंड इम्पैक्ट होता है इसका. देखें, सीटाग्लेप्टिन जो होता है विद DPP-4 एंजाइम के साथ वो कोवैलेंटली बॉन्ड नहीं होता, लेकिन विल्डाग्लेप्टिन का मॉलिक्यूल होता है इट इज कोवैलेंटली एंड परमानेंटली बाउंड विद DPP-4 एंजाइम, एंड इनहिबिशन बाय विल्डाग्लेप्टिन इज मोर प्रोफाउंड एज कंपेयर्ड टू सीटाग्लेप्टिन. तो विल्डाग्लेप्टिन का इफेक्ट बहुत ज्यादा अच्छा आता है एज कंपेयर्ड टू सीटाग्लेप्टिन. ये बड़ा माइनर सा इफेक्ट होता है. अगर आप देखें तो आपको विल्डाग्लेप्टिन के रिजल्ट बहुत ज्यादा प्रोफाउंड मिलेंगे. तो इसमें माय चॉइस, आई डोंट हैव एनी preference, but my choice is vildagliptin over sitagliptin. Why? Because the covalently bounding of DPP-4 enzyme is profound with vildagliptin. तो इसमें दोनों का इफेक्ट बहुत अच्छा है, दोनों आप कर सकते हैं यूज. और दोनों रीनल फ्रेंडली हैं, दोनों का वेट न्यूट्रल इफेक्ट होता है और दोनों टाइम टेस्टेड ड्रग्स हैं, तो आप दोनों कर सकते हैं यूज whichever suits you और whichever is available, that is also very important. अच्छा, और कोई सवाल इसमें आपने पूछा SGLT2 चैनल, देन sir, early it acts on SGLT2 channel, then why it is not used in type 1 diabetes? देखिए, मैंने अभी मेंशन किया था कि SGLT2 inhibitors का रोल टाइप 1 डायबिटीज में भी आ रहा है, बट देयर आर सर्टेन पेशेंट्स वेयर यू शुड नॉट यूज इट if their glucose control is not good, if they have a history of DKA or recurrent UTI, there you are not going to use SGLT2 inhibitor in type 1. Type 1 diabetes में भी इसको बहुत ज़्यादा एक्सप्लोर कर रहे हैं because it is beyond insulin control. तो इंसुलिन के पाथवे से हट के इसका इफेक्ट होता है. It only leads to hyperglycosuria, and by doing so, it will improve glucose control. Maybe it will also lead to reduction in the insulin dose. लेकिन ये बात याद रखें कि मेन ट्रीटमेंट टाइप 1 में इंसुलिन है, उसमें आप ऐड कर सकते हैं मेटफॉर्मिन, उसमें आप ऐड कर सकते हैं SGLT2 inhibitor, preferably if the patient is a suitable candidate. लेकिन of course you have to utilize the therapy and check your patient glycemic profile. Kindly tell me early to work diabetics and cardiac cancer. What is cardiac cancer? ये सवाल इन्होंने पूछा है डॉक्टर अदनान आदम. Kindly tell me early to work diabetics
and
cardiac
cancer.
ये आप अगर बताना चाहें तो we can also tell us verbally. क्या आपका सवाल क्या है सर?
Dr. Aslam साहब, I think नहीं, I think he has left. नहीं, वो रिलीव हो गए शायद. Sir, last question है.
हाँ जी.
Sir, last question आया है. That is, sir, can you tell us about empagliflozin dual combination with molecules other than metformin? For example, empa plus sita.
Oh, empagliflozin का अब तक कॉम्बिनेशन आया है विद मेटफॉर्मिन, और एम्पा और सीटा कॉम्बिनेशन अब तक मेरे इल्म में नहीं आया है. इट विल बी यूनिक कॉम्बिनेशन अगर आपके पास कोई ऐसी नॉलेज है. अलबत्ता लेट मी टेल यू वन थिंग, SGLT2 inhibitors have been tried with another incretin molecule which is GLP-1 receptor agonist, और इसका बहुत ज़्यादा profound impact आया है. आपको पता है कि we have liraglutide and we have dulaglutide. These are two GLP-1 receptor agonists available currently in Pakistan, and combining these two very beneficial cardiovascular drugs, एक तो आपकी GLP-1 receptor agonist है, उसका cardiovascular बहुत ज़्यादा benefit है. और आपको पता है कि लीडर ट्रायल आपने सुना होगा, रिवाइंड ट्रायल सुने होंगे आपने, अवार्ड ट्रायल सुने होंगे आपने. ये वो ट्रायल हैं जिसमें GLP-1 रिसेप्टर एगोनिस्ट को स्टडी किया गया है बहुत डिटेल में. दूसरी तरफ से हमारे पास एम्पाग्लिफ्लोजिन है, वी हैव डैपाग्लिफ्लोजिन. दीज ड्रग्स वर कंबाइंड नॉट इन अ सिंगल मॉलिक्यूल, नॉट इन अ सिंगल मेडिकेशन, बट सेपरेटली. एज अ टैबलेट we have SGLT2 inhibitor, as injectable we have GLP-1 receptor agonist. इनका कॉम्बिनेशन जो है ट्राई किया गया है और उसका बहुत ज्यादा प्रोफाउंड इम्पैक्ट आया है ऑन ग्लाइसेमिक कंट्रोल एज वेल एज मेटाबॉलिक कंट्रोल एंड कार्डियोवैस्कुलर बेनिफिट. तो ये एक चीज है जो कि हम आगे चल के देखेंगे कि हमारी अभी प्रैक्टिस होती है. आई होप आई हैव आंसर्ड योर क्वेश्चन.
ठीक है. Thank you, Dr. Hassan, for sharing your knowledge and making it a very informative session. This was very brilliantly put. आपका बहुत-बहुत शुक्रिया. I would now like to move on to our next speaker. And the thing is that what is a knight that cannot, the knight not only jumps on its adversaries, but it moves are always 3 by 2. Similarly, empagliflozin provides end organ safety in cardiovascular events. For that, I would like to invite our second speaker, Dr. Mohammad Faisal. Dr. Mohammad Faisal is an FCPS in cardiology, and he is currently serving in civil hospital. Dr. Saab, please on to you now. Dr. Faisal.
Hello, assalamu alaikum. Hello.
Yes, sir.
Can you hear me?
Yes, sir. Sir, we can hear you. आप क्या कहते हैं? Please share your screen with the presentation.
जी बिल्कुल, एक सेकंड. Can you easily visualize my presentation? Hello.
Yes, sir.
Can you easily visualize my presentation?
Yes, sir. We can.
So my name is Dr. Faisal Ahmed, and I am working as a consultant cardiologist in the Department of Cardiology, Civil Hospital. Basically, all the aspect of SGLT2 is well and very efficiently described by Dr. Hassan. So I will be giving a very brief aspect of the empagliflozin on the cardiovascular remodeling and cardiovascular mortality and morbidity. As we all know that mostly all the empagliflozin affects on the proximal tubule, and 90% of our SGLT2 glucose is dropped from our proximal tubules. So we can have a significant reduction in our HbA1c, significant reduction in our weight loss, and as we all know, we can have a better reduction in the blood pressure. As well said by Dr. Hassan, that most of the patients can have a diuretic effect with this drug because of the increased glucose in the urine. So when most of the time in the heart failure patient, when we combine this drug along with the other heart failure drugs, most of the time we have to reduce the dose of the diuretics in our patient. It's only because of the diuretic effect of this drug. And this is the excellent beauty of this drug, that we are able to reduce the dose of the diuretic in our patients. So this is a one more renowned trial, that is the EMPARAC trial, in which there was a comparison between the placebo and empagliflozin 10 milligram and empagliflozin 25 milligram. So in this trial, they compared all the two doses, the 10 milligram doses and the 25 milligram. And what they see is that the primary endpoint was the heart failure, hospitalization, and the cardiovascular death, and hospitalization from the heart failure and all-cause mortality. And they got success in all the three domains. The heart failure hospitalization was reduced, there was a mortality benefit, and the hospitalization because of the heart failure was also reduced, and the all-cause mortality was also reduced in the patient who were added in the empagliflozin group. And more reduction was noted in the patients who were taking the drug in the 25 milligram. But the focus updates in the 2021 shows that 10 milligram has also a better effect in the patients rather than patient not taking the empagliflozin group. So these were the baseline characteristics for the patient who were taking these drugs. The age group was almost similar in both groups, and the body mass index was approximately similar. It was more than 25. The HbA1c was approximately around 8. So we can easily see the baseline characteristics, the demographics, and the diabetic status was almost similar among all the participants of the group. So what the primary outcome was achieved was it was simply like the cardiovascular हेलो
जी सर, आपकी आवाज जी सर आपकी आवाज आ रही है, प्लीज कंटिन्यू।
अच्छा ठीक है, मैं अपनी स्लाइड शेयर करता हूँ।
जी जी
स्लाइड शेयर हो रही है मेरी?
जी सर।
ठीक है, सॉरी फॉर इंटरप्शन. So with this graphical representation, you can easily see there were three groups. One group was taking the placebo, the other group was taking the empagliflozin 10 milligram, and the other group was taking the empagliflozin 25 milligram. And the group which was taking the empagliflozin 25 milligram, and there was significant reduction in the heart failure, hospitalization, and the cardiovascular death according to this data. So the hospitalization for or death from the heart failure was also reduced, and the p-value was very much significant, less than 0.05, and the confidence interval was obviously less than 1. So the patient who were having the empagliflozin, and make sure all the patients should have all the guideline directed medical therapy along with this drug. I'm not saying the patient should only be having this empagliflozin, but patient should be on all the heart failure regimes. Like if a patient is having ischemic cardiomyopathy, he should be on like antiplatelet, anti-beta blockers, ACE inhibitors, ARBs, or nowadays we are having sacubitril valsartan known as angiotensin receptor nebulizing inhibitors. And if a patient is having ejection fraction of less than 40, he or she should be on the spironolactone or eplerenone. After that, we can add this drug as an add-on drug. If patient is not on the maximal tolerated guideline directed medical therapy, so first we have to optimize the drugs rather than putting him directly on this drug. So now coming back to the topic, so what about the all-cause hospitalization? The hospitalization because of the heart failure, hospitalization because not of the heart failure. So all was reduced on the group which were taking the empagliflozin rather than the placebo. This is this is another bar graph. Heart failure.
सर प्लीज अनम्यूट कर लीजिए. जी आपकी आवाज आ रही है.
So nowadays we are prescribing this drug in patient also with the heart failure, preserved ejection fraction, along with the patient with the heart failure with reduced ejection fraction. So not only in diabetic, also patients who are not diabetic, we can also prescribe this drug to those patients also. So this is there's a beneficial effect in patients either diabetic or not diabetic of this drug in both scenarios. So what was the cardiovascular safety of this drug? So the cardiovascular safety, as you can easily see, there was a relative risk reduction of 35% for the patient of hospitalization for the heart failure, and there was a 38% mortality benefit of cardiovascular death, and the all-cause mortality was also reduced 32%. And you can easily see the 30 number is a big number. If you are reducing the 30% mortality with a single add-on drug, you are giving a lot of benefit to your patients. So nowadays, we all cardiologists are adding this drug. Either patient is a diabetic or patient is not a diabetic, we can easily add on this drug. And last focus updates, I don't have those slides with me right now, but I can share with you in the future. The focus updates of the heart failure, the latest focus update according to the American Heart Association clearly says that we can easily prescribe this drug in the patient either diabetic or not diabetic, mostly in the patient with the heart failure with the reduced ejection fraction, because it has a lot of benefits in the cardiovascular remodeling. So it has a significant reduction in HbA1c. It has already been told by Dr. Hassan. There is a significant weight reduction in weight, and it is very, very much mandatory for our cardiovascular patient, because with the reducing weight, you can definitely reduce the cholesterol level of our patient and provide a better healthy lifestyle by reducing the blood pressure, cholesterol, and having a better sugar control with the reduction in the sugars. And obviously, this is a weight-friendly drug, and as the data says, it can help your patient in reducing the weight. So with the weight reduction, we all know with the weight reduction, we can reduce the systolic blood pressure of our patient. So when compared with the local diuretics available in our market, so mostly it does not have any resistance. And other than that, it decreases the blood and plasma volume, decreases the left ventricular and diastolic volume, because it decreases the preload as well as it decreases the LV hypertrophy. When we are going to regress the LV hypertrophy, we are going to increase the compliance of our LV and decrease the remodeling. Definitely decrease in the heart failure and decrease in the cardiovascular mortality. On contrary, furosemide, we all know it's not a kidney-friendly drug. Ultimately, it damages our renal tubules and it has no mortality benefit. It only has a symptomatic benefit. This is a good pictorial presentation. You can easily see if a patient in a picture A is not on SGLT2 and the patient is having a heart failure, he or she can have a concentric hypertrophy, or if he or she is hypertensive, or he or she can have an eccentric hypertrophy, in which the chamber size along with the mass is going to increase. But if we put those patients on SGLT2, the left ventricle size is going to increase, the inflammatory process, because it also works as an anti-fibrotic or anti-inflammatory for the cardiovascular point of view. So it inhibits the remodeling process and inhibits the apoptosis and maintains the integrity of our heart, and definitely it reduces the remodeling effect of our heart. So in this pictorial presentation, you can easily see it's basically maintain our interstitial, how it basically maintain our interstitial volume. So this is a receptor mechanism through which the SGLT2 affects, and all the receptor mechanism is very well explained by Dr. Hassan, how it affects on the proximal tubule and how it inhibits the absorption of the glucose by inhibiting the counter transport of the sodium. So what are the protective mechanism underlying the SGLT2 associated? Improvement in the ventricular loading condition through reduction in the preload. As I will told you, it has an effect of diuresis, natriuresis, because it works as an osmotic diuretic. It reduces the preload, and it has also effect on the afterload. It affects the cardiac metabolism and bioenergetics. It causes reduction in the necrosis and cardiac fibrosis, and it also has an anti-inflammatory effect by alteration in the adipokine, cytokine production, and epicardial adipose tissue mass. So this is a pictorial representation how SGLT2 inhibitors work, like decrease inflammation, decrease fibrosis, decrease hyperinfiltration, and decrease HbA1c reduction, decrease total body weight, and improve the cardiovascular outcome. It also helps in decreasing the blood pressure by decreasing the preload, and also has effect on the afterload by regular, and it maintains the reduces the definitely the HbA1c levels by through the kidney. So this, the mechanism of the renal and the cardiovascular protection, which I have explained you in the previous slides. It is the same slide. So what are the major risks and benefit of the SGLT2? Simply, this for our cardiovascular patient is for what? When a patient is hyperglycemic, definitely he or she is going to retain salt and water. When he or she is going to retain salt and water, that is going to precipitate the symptoms of the heart failure. Simply, they are going to have the symptom of the diabetic ketoacidosis. They are going to have the symptoms of the diabetic foot and claudication, acute limb ischemia, critical limb ischemia, amputations. And when we control the sugars via the SGLT2, we are going to have a marvelous effect like the reduction in the HbA1c, significant weight loss, reduction in the blood pressure, reduction in the mean adverse cardiac events, reduction in the hospitalization. These are all the benefits on contrary with the risk of not adding this drug. So this drug, along with the new drug, new two heart failure drugs, which are newly added on in the last couple of years since 2015, like ivabradine and the angiotensin receptor neprilysin inhibitor. This drug has also shows marvelous mortality benefit in our patient and had reducing the doses of the diuretic. Mostly when we add this drug along with other mortality benefit drugs, sometimes we stop the furosemide because patient doesn't need those drugs on long-term accounts. So this is the cardiac and renal protection chart. You can easily see how it works as a by glycosuria and natriuresis. Simply, it works as a decrease in the inflammation, decrease in the fibrosis, inhibit the cardiac remodeling, increases the cardiac mortality, decreases the atherosclerosis, decreases the chances of the ventricular arrhythmias, and decreases the interglomerular hypertension and decreases the hyperfiltration. So with all this effect, it provides the better mortality and morbidity benefit to our all the cardiovascular system. Cardiovascular system, as you all know, comprises of both the heart and the peripheral vessels. So it is beneficial for our vascular system also. It is beneficial for our cardiac system also. So with this, I'm going to end up my presentation. If is there any query you guys are open to ask me.
Thank you very much, Dr. Ahmed Faisal. If anyone has any questions for Dr. Faisal, please you can write in the chat or you can unmute yourself and ask them right now. I'll repeat myself. If anyone has any question for Dr. Faisal, please unmute yourself and ask them, or you can even write them in the chat. Dr. Saab, if anyone has any questions, then I'll get those two questions back to you. Thank you very much for your very informative session and for your brilliant insights into the CV events related to empagliflozin. Thank you very much. Now, I would like to move on to our next speaker. So, what is a knight that cannot end the game without a checkmate? Empagliflozin not only prevents CV events but also CKD events. For that, I would like to invite our third speaker, Dr. Aisha Ejaz. Dr. Aisha Ejaz is an MBBS, and an FCPS in nephrology, and she is currently working as a consultant nephrologist in JPMC. Dr. Saiba, towards to you.
Good afternoon, everyone. I'm Dr. Aisha, working as a consultant nephrologist in JPMC. I'm thankful to Farmivo for inviting me for the discussion and to create a platform where a endocrinologist, a cardiologist, and a nephrologist can talk together on one molecule. Dr. Hassan and Dr. Farooq has given a Dr. Faisal has given a very useful and beneficial discussion in diabetes and its beneficial effects in cardiac patient. And I, being a nephrologist, will highlight the useful and renoprotective benefits of SGLT2 receptors, empagliflozin. There are many renal benefits of SGLT2 receptor inhibition that have been proposed, that is decrease intraglomerular pressure, decrease glucose, decrease BP or arterial stiffness, decrease volume, decrease inflammation and fibrosis in the kidneys, that leads to decrease albuminuria, decrease oxidative stress, and decrease intrarenal angiotensin upregulation. Diabetes associated renal vascular changes. This is a very useful diagram. In the first diagram, that is in the diagram labeled as A, it is shown that when there is diabetes in the early stages of diabetes, there is increased intraglomerular pressure and increased hyperfiltration. That leads to dilated afferent arteriole, dilated fibrotic loops, and eventually proteinuria, and that proteinuria damages the kidney. Whereas when an SGLT2 receptor inhibitor is given, there is decreased intraglomerular pressure and decreased afferent arteriole constriction. That leads to decreased intraglomerular pressure, decreased GFR, and decreased proteinuria. This is explained in the further diagram. GFR changes in diabetes patient and the mechanism of renal benefits with SGLT2 receptor inhibitor. This is a very useful pictorial representation. In the first diagram labeled as A, the normal physiology of the kidney is shown. What happens in normal kidneys? The SGLT2 receptor inhibitor, that is sodium glucose reabsorption, that take place in the proximal tubule where the SGLT2 receptors are located. In the normal kidneys, there are normal GFR and normal tubuloglomerular feedback at the macula densa that leads to appropriate afferent arteriole tone, and the kidneys are functioning normally. What happens in diabetes? In the early stages of diabetic nephropathy, there is hyperfiltration, and that hyperfiltration leads to elevated GFR. There is increased sodium glucose reabsorption as the SGLT2 receptor. This leads to decreased sodium delivery to the macula densa. What happens when there is decreased sodium delivery to the macula densa? There is impaired tubuloglomerular feedback, and this leads to elevated GFR and afferent arteriole vasodilation. This is the mechanism that leads to increased GFR and increased proteinuria, hyperfiltration in the early stages of diabetic nephropathy. When SGLT2 receptor is given to the patient, there is SGLT2 receptor inhibition in the proximal tubule, and that leads to increased sodium delivery to the macula densa. When there is increased sodium delivery, the tubuloglomerular feedback is restored. This is very important, that when the tubuloglomerular feedback is restored, there is normalization of GFR, afferent arteriole constriction, and this all leads to protection of the kidneys. That is the hyperfiltration that is reduced, and the hyperfiltration that leads to proteinuria that is decreased. Empagliflozin renal outcome, that is the EMPA-REG trial. This is a very long study that is done over a period of 3.2 years, and that shows the renal outcome in patients using empagliflozin, and it shows that those patients who were using empagliflozin, there is decreased incidence of worsening nephropathy or cardiovascular death. there is decreased progression to macroalbuminuria. That is very important in diabetic kidney, because basically in diabetic kidneys there is early diabetic changes that leads to microalbuminuria and then macroalbuminuria, and then when there is decreased progression to macroalbuminuria, there is safety to the kidneys. The doubling of serum creatinine was decreased, and initiation of renal replacement therapy was decreased over the period of years, and there is decreased incidence of albuminuria. Similarly, the study this shows that those patients who were using empagliflozin, there is decreased incidence of worsening nephropathy as compared to other patients or as compared to placebo. And similarly, post hoc renal outcome, composite outcome was favorable in patients who were using empagliflozin. Renal outcome over a period of 3.2 years in patients using empagliflozin. The study shows that those patients who were using empagliflozin, there is 12.1%, 12.7 or 39% decrease incidence or worsening nephropathy. There is decreased post hoc composite outcome and 11.2% reduction of progression to macroalbuminuria. And this all is very favorable outcome when diabetic nephropathy or a patient who has microalbuminuria or worsening nephropathy is considered, that there is decreased incidence of worsening nephropathy and decreased progression to macroalbuminuria, that is the GFR is maintained or the progression of renal failure is decreased. This slide shows the potential mechanism of the favorable outcome of empagliflozin, that it decreases the blood pressure, decreases body weight, decreases arterial stiffness, increases cardiac function, decreases cardiac oxygen demand, and lack of sympathetic nerve activation. There is sodium depletion and decreased oxidative stress, increased glucagon secretion. So SGLT2 receptor inhibition, that is empagliflozin, leads to reduction of cardiovascular death, overall mortality, and heart failure hospitalization. This slide is already discussed by Dr. Faisal and Dr. Hassan, that what happens when a patient is using empagliflozin, what are the effects that leads to decreased glycosuria and decreased natriuresis. These are the basic mechanisms that leads to negative caloric balance and decreased HbA1c, and this all leads to decreased body mass, decreased inflammation, and glucose toxicity. There is decreased epicardial fat and decreased inflammation and fibrosis. And similarly, there is increased glycosuria that leads to decreased plasma uric acid and decreased atherosclerosis, and that has beneficial effects on cardiac and renal protection. Similarly, natriuresis leads to decreased blood pressure and decreased plasma volume, and this leads to decreased arterial stiffness and decreased myocardial stress. There is increased tubuloglomerular feedback that leads to afferent arteriole constriction, as already discussed, and this leads to decreased intraglomerular hypertension, decreased filtration, and this all has greater benefits on cardiac and renal protection. So empagliflozin available in 10 milligram and 25 milligram. And this all is from my side. Any questions that are welcome.
Thank you very much, Dr. Saiba. If anyone has any question for Dr. Aisha, you may please unmute yourself and ask them, or you can even write them in the chat box. Dr. Faisal के सवाल थे यार। नहीं वो डॉक्टर फैसल के सवाल है, वो डायरेक्ट Dr. Faisal, there was a question for you by Dr. Naveed, but it was sent to the private inbox. If you can answer the question is, can empagliflozin early be prescribed to non-diabetic patient with cardiac problems?
Hello, assalamu alaikum. Thank you, Dr. Naveed. It's a beautiful question. As I have discussed in my presentation, this slide wasn't mentioned. The latest updates, according to the American Heart Association 2021 updates, clearly mentioned that if patient is a cardiac patient and he or she is having a reduced heart function, like ejection fraction is less than 40%, you can prescribe the empagliflozin safely into the patient if the estimated GFR is more than 20. So it's not mandatory that he or she should be diabetic, but without diabetes, you can prescribe this drug for the sake of the cardiovascular mortality and morbidity in such patients.
Thank you, Dr. Saab. If anyone has any questions for Dr. Aisha, you may please ask them now by unmuting yourself, or you can even write them in the chat box. Okay, so there's a question for Dr. Aisha. Since the renal and urinary systems are linked, empagliflozin increases incidence of UTI. Would you still call it renal protective?
Yes, very nice question, Dr. Uzair. Yes, we can call the drug as renal protective. It increases the incidence of UTIs, but that incidence is not too much. And since we are using empagliflozin in our patient, the only thing that you have to monitor is that the patient has a GFR of greater than 30 to 40 ml per minute. If the patient GFR is okay, you can safely give the drug in renal patients. The only contraindication in renal patient is that if the GFR is less than 30, and there are studies being done on those patients who have GFR of less than 30, and empagliflozin is being used in those patients. But in our setups, we are using empagliflozin in those patients who have a GFR greater than 30 and 45 ml per minute. You can safely give empagliflozin in renal patients.
Thank you very much, Dr. Aisha. If anyone has any other question, we'll take a few more questions if anyone has any more questions. Okay. Thank you very much to the speakers for imparting their knowledge on all of us, and to the audience for being part of today's program. As the master of the ceremony today, I knight you, the audience, as the future Knights of Diabetes with the knowledge that you have been given today by our expert speakers. With this, I formally end the session. May Allah keep us all safe and healthy. Pakistan Zindabad. Assalamu alaikum.